Good morning, everyone. I would like to begin by thanking the AGA for giving us the opportunity to present our research at TDW. Our presentation is titled Prediction of Progression in Barrett's Esophagus using a Tissue Systems Pathology Test, a pooled analysis of international multicenter studies. Progression in Barrett's esophagus, particularly in patients without dysplasia, is uncommon. Progression in those with low-grade dysplasia, while somewhat higher, is also variable, likely due to the significant heterogeneity in the histopathologic interpretation of low-grade dysplasia. This has led to the recommendation for both surveillance and ablation in those with low-grade dysplasia. At this time, the dysplasia grade is the sole determinant of management recommendations in those with Barrett's, as written by most GI societies. Recommendations range from surveillance every 3 to 5 years in those with no dysplasia, to endoscopic eradication therapy or surveillance in those with low-grade dysplasia, and endoscopic eradication therapy in those with high-grade dysplasia given their substantial high risk of progressing to esophageal adenocarcinoma. However, this approach has significant limitations. The risk of progression is variable even within the same strata of dysplasia, indicating that dysplasia alone is not the sole risk factor responsible or predictive of progression. Indeed, as seen in this table, increasing age, male gender, current or prior smoking, and the length of the Barrett segment are independent predictors of progressing to high-grade dysplasia or esophageal adenocarcinoma. Medications such as statins and PPIs have also been implicated as being protective in progressing towards high-grade dysplasia or adenocarcinoma. This has led to surveillance, particularly in those with non-dysplastic Barrett's, to not be cost-effective. In addition, endoscopists are not generally compliant with surveillance recommendations, leading to a fairly high missed dysplasia or adenocarcinoma rate at 25 to 33%. Hence, prediction of progression in Barrett's esophagus has been attempted given the substantial implications of making this prediction accurately. Such a prediction algorithm could lead to personalized management, with a change in management of those deemed to be at low risk of progression, leading to either a decrease in the frequency of surveillance or stopping surveillance altogether, whereas those with high risk of progression could be subjected to either intensive surveillance or perhaps even proactive ablation if the prediction algorithms are extremely accurate. This has the potential of making Barrett's management more efficient and cost-effective by targeting surveillance to those at higher risk of progression and preventing adenocarcinoma development in those patients, as well as decreasing the costs of ineffective or unnecessary surveillance in those at low risk of progression. It is in this background that the TissueCypher assay was developed. This assay is a laboratory-developed test done in a CLIA-certified laboratory performed on formalin-fixed paraffin-embedded tissue. The assay uses a multiplexed fluorescence imaging platform that automatically extracts quantitative data on 9 tissue biomarkers and nuclear morphology and uses a multivariable classifier that integrates quantitative image analysis data to provide a risk score from 0 to 10 and risk classes of low, intermediate, and high risk of progression to high-grade dysplasia or esophageal adenocarcinoma within 5 years. The aim of this study was to assess the predictive ability of this tissue systems pathology test performed on paraffin-embedded tissue to predict incident progression in Barrett's patients either without dysplasia, with indefinite dysplasia, or low-grade dysplasia by combining patient-level data from 4 independent case control studies done in institutions in the United States and Europe. This slide summarizes the 4 studies from which data from individual patients was pooled. The first study is a retrospective nested case control study performed from tissue from the United States and the Netherlands with 79 progressors and 287 non-progressors, from which the initial 3-tier classifier was developed. The next study is a recently published retrospective case control study using an independent sample of progressors and non-progressors, wherein this 3-tier classifier was validated. The fourth study is a retrospective nested case control study nested within the Rebus Netherlands prospective cohort of patients with no dysplasia, in which 38 progressors and 38 non-progressors were studied, and the 3-tier classifier from the prior 2 studies was applied to predict progression, in addition to both spatial and temporal analysis of specimens taken either at multiple levels from the same endoscopy or from multiple endoscopy. The last study used tissue from the screening cohort of the SURF low-grade dysplasia randomized control trial, wherein 155 patients with a community low-grade diagnosis were confirmed or refuted by a panel of academic pathologists, and the performance of the TissueCypher assay was compared to that of academic pathologists. Patient-level data, including age, sex, Barrett's length, presence or absence of a hiatal hernia, race in some patients, initial and confirmed pathology was combined. Non-progressors were matched to progressors by age and sex. Incident progression was defined as the development of high-grade dysplasia or esophageal adenocarcinoma more than 1 year after the initial Barrett's diagnosis. Multivariable conditional logistic regression was performed to test the association of the TissueCypher assay with progression. A comparison was made of the model prediction of progression using the C-statistic with and without incorporation of TissueCypher assay results, both in continuous form as well as in the categorical form, wherein the assay results were expressed as low risk, high risk, or intermediate risk. An a priori subset analysis of only patients with non-dysplastic Barrett's at baseline was also performed. These are the baseline characteristics of the cohort that was analyzed, a total of 475 patients from all 4 studies, of which 152 were progressors and the remaining were non-progressors. Almost 2/3 of this cohort had long segment Barrett's, about 1/3 were progressors, and approximately 1/6 had a high-risk TissueCypher risk class. This is the multivariable model of predictors of progression in all patients without incorporation of the TissueCypher results. As you can see, older age, expert diagnosis of low-grade dysplasia, and increasing Barrett segment length were independent predictors. The C-statistic for the model was 0.68. These are the results of the multivariable model with the inclusion of the TissueCypher results. As you can see, expert diagnosis of low-grade dysplasia continues to be a significant predictor. Barrett segment length continues to be an independent predictor of progression. A TissueCypher classification of high risk versus low risk substantially increased the risk of progression with an odds ratio approaching 8. The C-statistic of this model was 0.76 compared to the previous model of 0.68, and indeed a likelihood ratio test comparing the C statistic of the model with versus without the TissueCypher was very significant, with a p-value of less than 0.0001. This is a multivariable model of prediction of progression in those only with non-dysplastic Barrett's without incorporation of the TissueCypher results. And again, age at diagnosis as well as Barrett segment length were independent predictors of progression with a C statistic of 0.62. When we add in the results of the TissueCypher to the analysis on patients with non-dysplastic Barrett's, a TissueCypher risk category of high versus low is associated with an 18-fold increase in the risk of progression, whereas a TissueCypher risk classification of intermediate is associated with a almost twofold higher risk of progression. Notably, the C statistic increased from 0.62 to 0.72. And similarly, the likelihood ratio test of the comparison between the C statistic of the model with versus without the TissueCypher was very statistically significant. So what are some advantages of the TissueCypher assay? It can be done on formalin-fixed paraffin-embedded tissue and hence does not require any specific kind of tissue acquisition. Second, the analysis is automated and quantitative and hence has the advantage of lack of subjectivity in its analysis. Third, methods and cutoff thresholds for determination of the risk levels have been standardized and have been set. And as I've shown you in the prior slides, the results have been validated in at least 4 independent sample sets, establishing its utility not only in those with low-grade dysplasia, but also in those with non-dysplastic Barrett's, where oftentimes risk prediction is much more challenging and current recommendations are those of surveillance only. In conclusion, progression rates are low in non-dysplastic Barrett's esophagus, making current surveillance practices inefficient. Prediction of progression in Barrett's esophagus using clinical parameters alone have modest accuracy. And as we have seen in this presentation, the addition of validated biomarker panels such as the TissueCypher can augment the accuracy of this prediction, with the implications that the management of patients with Barrett's esophagus could be personalized, with those at low risk perhaps being surveyed less often, and those with high risk being surveyed more intensively or being subjected to proactive ablation. Thank you.